My name is Sybil Hoiss. I lead clinical initiatives and innovation with Critical Care BC. I've been a critical care nurse for 15 years now, and I'm also the adjunct professor with UBC School of Nursing. I'm a recent grad of the Sepsis Canada Lifting Research Training Program. As David mentioned, I do have experience as the provincial quality lead of the BC Sepsis Network that's under Health Quality BC. We updated the provincial adult ED sepsis guidelines and did some dissemination and implementation work with that. I am grateful to be joining from the traditional and unceded lands of the Secwépemc people here just outside of Kamloops, which is right in the middle of BC. And I would like to welcome you all to session 3, which is Sepsis Redefined, where we'll explore varying methods of sepsis classification and coding. And we're joined today by experts working in this field, Dr. Hallie, Dr. Hallie Prescott, and Dr. Allison Watts. And our first presenter this morning, Dr. Hallie, is an associate professor and health data scientist in the Department of Community Health Sciences at University of Calgary. Her research applies artificial intelligence technologies and methodologies to enhance learning health systems using high quality and large scale electronic health data. So thank you for sharing your knowledge with us, Dr. Lee. I'll hand it over to you so you can teach us a little bit more about unsupervised clustering for sepsis identification.
Hey. Can you hear me well? Thank you. Hello, everyone. Thank you so much for inviting me, and thank you for being here. We know that patients often present in complex and heterogeneous ways, especially when it comes to sepsis. Some patients arrive in clear septic shock, which is easy to recognize, but many start with very subtle changes, like a small change in mental status or a decline in function. These presentations are exactly the ones our current definitions tend to miss. So in practice, which counts as sepsis depend on which system is looking. For example, administrative coding, clinical judgment, or research studies, each may tell a different story. So the question I'm interested in is, instead of starting with a fixed definition, can the data itself show us how sepsis clusters in clinical practice, including the presentations that may fall outside clinical rules? So in this presentation, I will walk you through how we could approach data-driven sepsis identification using an unsupervised clustering approach. And here's my disclosures, just given the time, I won't read it out. And as mentioned earlier, the main barrier to identify sepsis is that there is no universally accepted gold standard. Different systems use different algorithms, and they don't always agree. And broadly speaking, there are two approaches. The first is code-based algorithms based on hospital discharge abstracts, and the second is electronic health record-based definitions, such as the adult sepsis event definition. And code-based approaches using ICD or CCI codes look for combinations of infection and organ dysfunction codes in the discharge abstract. They are easy to apply at scale, but they could reflect billing and documentation choices more than patients' clinical trajectory. And different studies use different codes and criteria, so the performance varies widely. But most of these algorithms actually under-capture sepsis, especially the milder or early stage cases that were not coded into the system. So when we use administrative codes, we tend to underestimate the true burden of sepsis. And EHR-based definitions, such as the adult sepsis event definition, or ASE, use timing of blood cultures, antimicrobials, and lab parameters for organ dysfunctions to capture sepsis. But they are defined with strict thresholds and timing windows. That means a patient can clinically have sepsis, but if their clinical parameters were just outside of the thresholds, for example, with 78 hours of antimicrobials instead of 4+ days, the algorithm won't be able to recognize it. There is also variation in the implementation of these algorithms. Different EHRs, different data quality, even data analysts can generate different outputs. So although ASE can improve sensitivity by capturing more clinical detail, it is just another reference comparator. It's not the gold standard. So in summary, code-based approaches are easy to use, but underestimating the true burden of sepsis. EHR-based algorithms capture more clinical detail, but depend heavily on data quality and threshold rules. Neither of these fully captures the heterogeneity of sepsis presentations, and combined with the burden of sepsis, that's what drives the push to explore AI methods for improved sepsis detection. And our team has developed and applied unsupervised clustering for sepsis detection. So the key idea of unsupervised clustering or unsupervised learning is that we start with unlabeled data, meaning we are not telling the model who does or does not have sepsis ahead of time. There are no predefined case control groups and no fixed rules for the model to match. The model just sees hundreds of clinical variables the way they naturally occur in practice or collected in the databases. The model then looks for structure in the data. For example, which patients tend to cluster together based on similarity of presentation, physiology, timing, and severity, so without being forced into a pre-existing definition of sepsis. And instead of asking, does this patient meet the rule, we ask, which pattern does this patient most resemble? This gives us a way to detect clinically meaningful subgroups and help us to realize the real-world heterogeneity of sepsis that rule-based definitions may oversimplify. So in this study, our objective was to develop and validate unsupervised clustering methods for sepsis detection without relying on predefined sepsis definitions. We analyzed a cohort of adult ICU patients admitted to 5 medical centers in Calgary between April 2015 and March 2017. We analyzed data including administrative EHR data and e-critical data for a total of 592 variables. And we started with over 6,600 ICU patients divided by fiscal year into a development cohort of 2015 and a validation cohort of 2016. And after data pre-processing, 231 variables met our data quality criteria. We then reduced them into 55 principal components after dimension reduction. And using these components, we compared 8 clustering algorithms across multiple internal metrics and stability statistical tests, and then selected the best performing model. The resulting clusters were interpreted clinically, and we trained an XGBoost model to predict cluster membership in the development cohort and then validate it in the external validation cohort. So this table shows the characteristics in the development and validation cohorts. We can see that they are heavily they are highly comparable and with all absolute standardized differences below 0.1. And using the adult sepsis event definition as a comparator, 21% of patients in the development cohort and 19% of patients in the validation cohort met sepsis criteria. And after running the unsupervised clustering model, which we identify as the best model, we identified 48 distinct clusters in the development cohort. 11 were classified as ASE majority clusters, representing about 78% of ASE positive cases in the development cohort. And the remaining 37 clusters were ASE minority clusters. The figure on this slide shows the patient observations projected onto the first 2 principal components, with the red points representing ASE majority clusters and blue points representing ASE minority clusters. The 2 groups are mostly well separated in the principal component analysis space. Although there is a small overlapping area in the center, that means observations in the overlapping area may correspond to the border cases that are harder to recognize using ASE threshold rules. And the blended clinical review showed that 10 of these ASE majority clusters were consistent with sepsis or septic shock. Patients in these clusters showed higher severity with greater use of antimicrobials, ventilation, and had longer hospital stays. The 37 ASC minority clusters largely reflected non-sepsis conditions such as respiratory, cardiac, overdose, or post-operative cases. The external validation also showed our model had good stability by considering the validation of the ASC majority clusters. We had 9 of those ASC majority clusters maintained with at least 50% of ASC positive cases in each cluster. So to our knowledge, at the publication date, this was the first large-scale study to apply unsupervised clustering for sepsis detection without predefined sepsis definitions of labels. The approach was able to identify clinically meaningful sepsis subgroups and highlighted the potential to capture cases that rule-based definitions may miss, particularly the milder or atypical presentations of sepsis. And what this work points towards is not only a better algorithm to identify sepsis, but a better way of representing sepsis in large-scale electronic health record data. And looking ahead, I think there are 2 directions that AI is already helping. The first one is federated learning. This allows model to train across multiple hospitals without sharing raw patient data. It improves generalizability, preserves privacy, and supports multi-site collaboration, which is essential if we want our models to reflect the full diversity of sepsis presentations across different settings and populations. And second is generative AI. This is useful not only for detection, but also for interpretation. It can summarize evidence, help explain why a model thinks a patient belongs to a cluster, and even generate synthetic data to improve training where certain rare phenotypes are underrepresented. It also opens the door to more personalized pattern recognition, especially for patients who do not fit into the classical presentation of sepsis. And lastly, and importantly, I would like to acknowledge my study team and collaborators. And thank you for your attention.
Thank you so much, Dr. Lee. That was fascinating. I learn something new every time I hear you talk. I'm curious if anybody has any questions for Dr. Lee. Okay, I have one. I was curious, how can we improve some sepsis coding for better diagnostic precision and data quality while minimizing those unintended documentation and workload on clinical teams? I'm curious how we can do that. We know that the clinical teams are pressed a lot with competing priorities and multiple patients within their load. And so how can we reduce the load on those people providing direct care?
That's a great question. I think I can only answer the question from methodology perspective.
Sure,
because
yeah.
I am not working in the system to collect data and do the coding specifically. But I do think for methodologists who are using those codes, for example, by capturing like sepsis or to identify specific cohort for research studies or developing tools, I do think it's important to realize the variability, which is not a bad thing in terms of coding, because variability is more like the underlying structure feature is not like a failure or a bias. So it's important to recognize the variability and the cause for those variability. And that's something I really want to learn more for. And the second one is I think identifying bias actually is also important. In that way, we can actually start to think about methodologies to systematically improve the identification of sepsis using coding and by combining with other data sources to improve the data quality. But the first thing is to realize where the biases actually come from those coding and data collection. And the third one I think could improve efficiency is by using some generative AI tools, but I don't know whether this is possible in the future, but definitely there is a huge potential.
Thank you very much. And I see a hand is up, but oh, Alan, hello. Go ahead.
Just like to make a comment about Na's talk, and I'd like to draw an important distinction between what she's trying to do and the prior talks about early warning scores, because they might seem superficially similar, but they're actually quite different. The early warning scores seek to locate hospitalized patients in real time who have sepsis based on some definition. Whereas what Na is talking about is seeking to better define and understand what sepsis is without a preconceived notion of what it is. So they're quite different from each other. The latter should not be confused with early warning scores, at least not at the current.
Thank you.
Thank you so much for the clarification.
Yeah, and Dr. Lee, we do have another question for you. We're wondering, did you encounter any resistance with using unsupervised clustering without predefined labels?
Thank you for that question. That's a really interesting question. I don't find resistance, but I do find misunderstanding, mainly because I think there are some misunderstandings about this methodology, and also this methodology may not be well known in the field, especially considering healthcare applications. But when we talk about data mining, it's probably more obvious by just using unsupervised clustering to clarify the goal for this kind of approach. Yeah, I'm trying to, as you can see from my presentation, trying to introduce the methodology first to separate what is unsupervised clustering and what is supervised prediction models, and as well as generative AI methods. So I'm working on that to try to explain the concepts and also try to actually publish more papers on introducing these different AI methodologies.
Thank you very much for your detailed answer and your presentation for sure. I think the world is really interested in learning from you for sure about this. So thank you very much for your presentation, Dr. Lee.
Thank you.
Yeah. Our second presenter this morning, Dr. Hallie Prescott, is an associate professor of pulmonary and critical care medicine at University of Michigan and the Ann Arbor Veterans Affairs Healthcare System. She's co-chair of the Surviving Sepsis Campaign Guidelines and leads a 69 hospital sepsis quality improvement initiative sponsored by Blue Cross Blue Shield of Michigan. Her research program focuses on the measurement, management, and outcomes of sepsis. So thank you for sharing your work with us, Dr. Prescott. I'll hand it over to you to teach us about the development of AlgorithmL.
Excellent. Great. Thanks, Sybil, for the introduction and for inviting me to be here today. So as mentioned, I'll be talking about development of AlgorithmL. I have one financial conflict of interest unrelated to this talk. The work was supported by CHR, and then I've listed other research funding, salary support, and just obliged to tell you these are my views, not views of US government or Department of Veteran Affairs. So this is the specific paper that I'll be talking about today. This was published in Critical Care Medicine in December of 2024. And I just really like to highlight the co-authors, including Na, who just spoke, and Alan, who's also on the line, and many others who may also be on the line here today. So I'll share a little bit about the background for this work, the methods used, results, and then sort of key implications. So as we know, sepsis is common and deadly, an estimated 50 million cases and 11 million deaths annually. And in most countries, national epidemiology is tracked using diagnosis code-based approaches to essentially measuring the burden of sepsis. But there are a number of kind of well-described limitations to these approaches, two of which I'll highlight here. The first is that there are a lot of different algorithms in place that are not all the same. And then this results in kind of widely varying estimates across studies. There's also in most of these algorithms essentially very little description about how the particular diagnostic codes were selected for inclusion or why certain codes were included versus not included. And then finally, there have been several calls for improved code-based identification algorithms to better estimate the burden of sepsis. And so really the goal of this work was to kind of, go through and use, a rigorous and a certainly more transparent approach to deciding which diagnostic codes should be included for identifying sepsis in sort of retrospective, studies using code-based approaches. So to do this, we started with 1,028 ICD-10-CA diagnosis codes for infection. And these were reviewed by a team of 4 physicians, all faculty at Canadian Schools of Medicine in either infectious disease or critical care. And for each of these nearly 2,000 codes, they were essentially evaluated on a 4-point Likert scale as being very unlikely, unlikely, likely, or very likely sepsis. Codes where there was consensus, meaning that the panel all felt that they were either on one side of this Likert scale or the other, were essentially then completed. But for codes where there was assessments on both sides of this Likert scale, we then proceeded to a second step of, again, a blinded review where the 4 panelists independently reviewed the codes, but this time they had access to the panel results. So they could see, for example, oh gosh, well, I rated this as a 1, everybody else graded as a 3. I better sort of, think about this a little bit more deeply. So this was a second round, again, with the full access to the data. And then after the second round, if things were still, split on both sides of this Likert scale, they were then brought for group discussion followed by a final vote. And then this exact same process was used to adjudicate diagnoses of acute organ dysfunction, so specifically 98 diagnostic codes for acute organ dysfunction, as well as 8 procedural codes. And this was a separate panel, all critical care physicians who, again, went through the same process, 3-step process to come up with essentially final assessments of the likelihood that either this infection could cause sepsis or that this acute organ dysfunction would result from sepsis. And so after having all of these, couple thousand codes adjudicated, we then took those adjudications and made these 2 algorithms, AlgorithmL and AlgorithmVL. So AlgorithmL, this stands for likely sepsis, and AlgorithmVL, very likely sepsis. Both of these algorithms will include hospitalizations with an explicit code for septic shock or infectious SIRS complicated by acute organ dysfunction. And then they also will both pull in what we call implicit diagnosis of sepsis, where there is both an infection code and an acute organ dysfunction. And so the likely AlgorithmL, likely sepsis, will include all of the diagnostic codes that had a median score in the final voting of 3 to 4. And then the very likely will pull in just that kind of subset where the final consensus score was a median of 4, meaning very likely to either cause sepsis or to result from sepsis. So then after these algorithms were made, we then applied this to Calgary data to determine annual population-based incidence of sepsis and case fatality rates and compare those estimates to the results generated from alternative approaches that have been previously described in the literature. So moving on to results, during this blind voting process, rounds 1 and 2, 84% of the infection codes achieved consensus and 76% of the acute organ dysfunction codes achieved consensus, leaving about 300 infection codes for discussion by the group and 22 acute organ dysfunction codes for discussion by the group. Ultimately, after that third round of voting, there was 720 infection codes and 50 acute organ dysfunction codes included in AlgorithmL, and then 99 and 19 included in AlgorithmVL. And so this shows this final consensus score. This is the median score across all the different codes, and then presented by the range. So you have a number over here where there was clear consensus that this was not likely to cause sepsis or be caused by sepsis. A number over here where there was clear consensus that this was likely to cause or be caused by sepsis, and then a small number of codes in the middle here where at the end of the day, there were still, votes on both sides of this Likert scale. So how does this number of codes compare to other approaches described in the literature? This table here from the manuscript shows the number of codes. And you can see, for example, the Angus code, which might be the most commonly cited approach previously used in the literature, had 267 codes and 33 organ dysfunctions. So sort of somewhere in the middle between algorithm L and algorithm VL. And for those people who are sort of really interested in the nitty-gritty details, I'm going to direct you to the supplement. I think it's one of the best supplements ever made for a paper. This is an Excel document that has all of the different codes that were considered, their name. It indicates whether they were included in algorithm L or VL, whether they're included in these prior different approaches, and the final consensus score. So sort of full transparency of the methods, all the details you may want about which codes are included. So this can be used in future research. So then taking these two algorithms and applying them to Calgary data, this here shows the overall population-based incidence per 100,000 adult patients, and then the mortality rate. So you can see here, algorithm L is the most sensitive, identifies 382 per 100,000 adults with sepsis hospitalization each year, with a case fatality rate of 18.7%. And then algorithm VL here identifies 150 with a 23% case fatality rate. That is pretty similar to what is identified by the Angus approach, but there are sort of differences in exactly which, who is included in one versus the other algorithm. So I think key takeaways of this work is I think it really does highlight how these algorithms differ in how many and which codes are included, and then shows directly how this results in variability in the estimated incidence and mortality, even when applied to the exact same data set. Algorithm L is the most sensitive, yielding 383 adults per 100,000. And to kind of put that into context, these are just some ballpark numbers for stroke, STEMI, pulmonary embolism, other kind of acute medical conditions. So you can certainly see that sepsis is quite common, about 3 to 4-fold more hospitalizations for sepsis compared to these other conditions. And then even when using this kind of sensitive algorithm L that certainly pulls in or includes less critical cases of sepsis compared to some other algorithms, we still have an 18% in-hospital mortality. So I think really underscores that we have more work to do to reduce the burden and mortality of sepsis. So I will close there and happy to take questions. Thanks.
Thanks very much, Haley. It was really nice to see the process of the development of algorithm L. I'm curious how an institution should use algorithm L. What do you propose? Is there a method or process?
Yeah, I mean, so this is like based on, I think, final hospital coding. So really is not going to be used sort of for like real-time identification or anything like that. Sort of as Alan highlighted, there's kind of like different, sort of use cases for these different sort of definitions. So I think this is really used for if you want to sort of understand your trends over time, how many sepsis cases, how many people have in hospital or 30-day mortality, this can be an approach that you can use to kind of fully capture the sepsis cases, in retrospect and monitor those trends over time.
Yeah, excellent. Another question I had was, how do the systemic consequences of over-identifying sepsis differ from those of under-identifying it?
Yeah, right.
Any
Trying to
thoughts on
right size
that?
the so many thoughts. Yeah. Yeah, it's interesting. I mean, I think like in the US at least, where there's a heavy financial incentive to label things as sepsis as opposed to infection, we've certainly seen like huge shifts over time that more and more sort of cases are being called sepsis. I think it's still important for us to sort of really distinguish people with sepsis, which, sort of I define, and like I think Sepsis 3 defines as acute organ dysfunction, this kind of injurious response to infection, because those are the patients where it's really time sensitive, it's really time critical. And I worry that if you sort of call everything sepsis, like anybody who's in the hospital with infection gets labeled as sepsis, people start to kind of like recoil against the need for urgency if you're putting everybody into this bucket, right? So I do think there's like this important to triaging, identifying the sickest of the sick patient, because it's kind of hard to treat every single patient in your entire hospital as a complete emergency. And so this happens with heart attack, right? Like we have STEMI, this is, like all hands on deck, this is super time critical. and then there's chest pain, which of course we want to evaluate, but there is this kind of like distinction between the two. And so I think that we need to, sort of recognize that, there is a distinction and, more sick and less sick patients.
Excellent. Thank you very much, Haley. Thanks for sharing your knowledge with us and the work of your group for sure for putting this all together. Our next presenter is Dr. Allison Watts. And so Allison is a project manager in the Department of Pediatrics of the University of British Columbia, working with the Lavoie Lab on research projects related to child health, such as RSV and sepsis. She has a PhD in epidemiology and community health from University of British Columbia. So thank you for sharing your work with us, Dr. Watts. I'll hand it over to you to teach us about the application of AlgorithmL to neonatal sepsis in BC.
Okay, thank you very much for having me. I want to present today a project that our team has been working on to quantify neonatal sepsis in British Columbia. So sepsis disproportionately affects neonates, and sepsis does appear differently in babies than it does in adults. The signs early on are often very difficult to identify, and symptoms are very nonspecific in babies, so you can't always use the typical criteria. And the diagnostic is often limited to a positive blood culture, but testing is not always 100%, and it's also not very sensitive in neonates. So there is a need to better understand how to define sepsis and determine the true incidence of sepsis in this specific population. And there are also very few population-based studies in neonates and none that are recent. So the objective then of our project was to determine the population-based incidence of sepsis among neonates in British Columbia, Canada, and also to quantify the incidence by gestational age. And investigating this will help to improve our understanding of neonatal sepsis, guide clinical decisions, and enhance sepsis management and prevention strategies. So for our study, we created a retrospective birth cohort of all live births in BC, and this included hospitalizations up to the first 28 days of life. And we used an administrative data set that was obtained from the BC Perinatal Data Registry. And the dates, the years that were included were 2004 to 2020, so 17 years of data. And this included all live births, so that's approximately 40,000 per year in BC. So to define our primary outcome of sepsis, we had two parts. So the first was to look at ICD-10 codes, and we wanted to identify all of the common infection-related ICD-10 codes which could potentially result in sepsis syndrome in the Canadian context and also in the neonatal population. And so to do that, we had a clinical expert review, so a neonatologist reviewing the ICD-10 codes, and we also had review of the literature to see what codes were being used for this population. And then the second part of the definition was any case with a positive blood culture. So as I mentioned, we wanted to review the literature to see what was in published studies, and we found that there were fewer studies that were focused on the pediatric population and none that were focused on neonatal sepsis specifically. So this is the list of infection-related ICD-10 codes that we identified. So we included both neonatal codes and adult codes because we had previous reports that neonates can sometimes be incorrectly classified using these adult codes. So we wanted to make sure we were capturing all potential sepsis cases. And then we also had these secondary sepsis definitions, similar to the previous presentation. So we had explicit sepsis, which were the ICD-10 codes that make explicit mention of the word sepsis. Then we had implicit sepsis, which is sepsis plus the addition of an ICD-10 code specific to organ dysfunction. Then we had just those who had a culture-positive sepsis. And then those classified as septic shock, which was sepsis plus a cardiovascular ICD-10 organ code or the ICD-10 code specifically for septic shock. These were the subset of ICD-10 codes that were classified as explicit sepsis. And then for implicit sepsis, these were the ICD-10 organ-specific codes that we used and the cardiovascular codes that were included for septic shock. So in our population of all live births, we had about 823,000. And these are the number of babies in our cohort with each of the sepsis outcomes definitions. So we had about 4,200 with sepsis. Of those, 3,200 approximately with explicit sepsis, 980 with a culture positive sepsis, 320 with implicit sepsis, and then 308 with septic shock. And I just want to point out some of our participant characteristics and that they do show that they were representative of the BC population. So looking at the ICD-10 codes, we did have babies that had both neonatal and adult codes. Just note that the scales are different here, so there was much fewer coding with adult codes. For the adult codes, though, the most common one was septicemia, other staph. And then for the newborn codes, neonatal codes, we had the most common being bacterial sepsis of newborn, followed by congenital pneumonia and sepsis due to staph. And we did also look at concordance with the mother's records to make sure that the adult codes were not just the mother's sepsis diagnosis being kind of inputted in error, and we did not find any evidence of that. We also wanted to look at the ICD-10 codes versus positive blood cultures, and we found that 77% of neonates with a sepsis ICD-10 code did not have a positive blood culture, but that 100% of the positive blood cultures did have a sepsis ICD-10 code, while 76% of those had an explicit sepsis ICD-10 code. So this shows the crude incidence of each sepsis definition as the incidence per 1,000 live births with 95% confidence intervals. So for sepsis, we had about 5 per 1,000. For explicit sepsis, about 4 per 1,000 live births. And then for implicit sepsis and septic shock, it was around 0.4 per 1,000 live births. And the gap is potentially wider than what you would see in adult studies because sepsis signs are very nonspecific, particularly in neonates, and the threshold to treat in this population is very low. And so you may get coding for sepsis during these investigations. This figure shows the incidence of the different definitions by gestational age. And so you can see that it's much higher in preterm. The most preterm infants had the highest rates, and you can see that the pattern is similar across definitions, although you do see a wider gap as the babies become closer to term. And that could be due to, again, rule-out investigations in the older babies who may show more unspecific symptoms. And then also looking at adjusted incidence rate. And this was adjusted for mode of delivery. So independent of if you were born by C-section or not, you can see that it was quite a large incidence in the youngest babies, the most preterm babies, and that is reduced slightly as you become closer to term. And then I also wanted to note that these population-based estimates that we are presenting are lower than what has been reported in previous kind of NICU-based studies. We also wanted to look at the type of pathogen, and we do show that it's a primarily bacterial sepsis in our cohort. And then we also looked across years and do see there is a trend towards decreasing sepsis across all definitions over time. So in conclusion, we found that sepsis incidence is highest in preterm infants, particularly the most preterm, and that estimates do vary up to 13-fold depending on which definition is used. And the current study is showing population-based estimates in preterm neonates, which are lower than previous studies, most likely because they were hospital NICU-based studies, which may overestimate the incidence of preterm, overestimate the incidence of sepsis in preterm neonates. Some of the challenges that we noted during this work was underestimation for specific diagnoses due to underreporting or undercoding. We did find that for certain ICD-10 codes that we expected to see, there was very low incidence. And then on the flip side, there was also evidence of over-identification because most neonates are evaluated for sepsis, or most neonates that are evaluated don't have the condition. Also, coding differences and a need for validation. So some ICD-10 codes in the BC context, we found that they were absent or they were grouped in our hospital data. So it does limit comparison between jurisdictions. And we also found that having no standard definition for neonatal sepsis does limit our precision of the estimates. So I'd like to acknowledge our team, particularly Eva Jensen, who is a master's student who conducted the data analysis that I presented, and also Pascal Lavoie, who led this work.
Thank you so much for sharing this work, Allison. This is fantastic, and the results are really interesting for sure. It seems there's a lot of variability in the way sepsis is coded, and that might be the definitions or the information put into patient charts, and then also the knowledge and expertise and experience of the people actually doing the coding. It's been a very interesting learning journey for me to figure out what that actually, like what that process is from being at the bedside to what that administrative data looks like. So this work is fantastic. Thank you very much. Is there anybody that has any questions? Oh, I see one in here. Allison, is there a difference in sepsis occurrence based on vaginal versus cesarean delivery? Great question, Shannon.
Yeah, I think I included a slide, not a very good slide, but it shows the bottom there, the mutually adjusted rate by mode of delivery. So it was higher in cesarean. And that's adjusted for gestational age. So you can see that it does have an independent increased risk.
Thanks, Allison. We have another question as well. What was the age range of included patients? Were 23 or 40 infants included in 43 or 40 corrected age?
Sorry, say that again?
So what was the age range of included patients?
Well, the only exclusion was, I think.
Maybe if I could clarify my question, if that's okay.
Thanks, Julia. Yeah.
So when you talked about the gestation, that was presumably the gestation at birth. And so how, like, what was the lag time of neonates who were was this all babies up to a month post-term corrected? And the reason I ask is, do you see a skew towards the more preterm because they have a longer time in which they're eligible to be measured in the study?
Yeah, that's a good point. I don't know if Pascal recalls. Sorry, Eva did this analysis, and I don't recall whether it was corrected age or not. But that's a good point, because it's basically any sepsis in the time that you're hospitalized. And we say up to 28 days, but if you're hospitalized longer, then some babies would have more. In this current analysis, opportunity to be diagnosed the longer, I guess, they were in the hospital. But that's something we'll look at for sure.
It looks like Pascal is set up to 28 days.
Yeah, but I don't know if that addresses her question.
I'll follow up with Pascal. Thanks.
Yep.
Okay, great. Thank you, guys. Any other questions for Allison? There was one question here for Hallie, wondering, Hallie, if you could explain how these codes are applied to someone who doesn't know the ins and outs of hospital coding. So the question is from a patient partner. So as someone outside of the system, they really had to go in to dig into the literature to understand what's meant by this and what the difference between classification based on clinical data and classification based on administrative data was.
Yeah. So I think, generally, the way that sort of hospitalizations, and I have more experience in the US, but the way that hospitalizations are sort of billed to insurance companies is that there's a list of diagnostic codes, essentially what the patient was treated for in the hospitalization. And at least in the US, like the payment is actually different depending on, what exactly the patient was treated for. So as a result, like these data are available at scale for like the whole country, right? So that's like a huge benefit, is sort of like it's a consistent form, it's a consistent data collection. And so, we can use that, but there's kind of limited kind of granularity of information there. And so that has led to this interest in trying to use clinical data from electronic health records to more sort of precisely, characterize or confirm infection, and like not only identify acute organ dysfunction, but sort of severity of organ dysfunction. So there's been this kind of movement, like the US Center for Disease Control and Prevention put forth this adult sepsis event criteria. Now, there's certainly more granularity and there's some benefits there. The big challenge is that there's huge issues in trying to get that data at scale, right? Like getting it across an entire country. Like people can do it for a single health system or a single hospital, but we really haven't had the capability to do that for a country. So those are kind of like the general, pros and cons of these, different approaches to really understand sort of at a large, like high kind of 50,000 foot view, how many sepsis cases are there? Are we making progress year upon year for like a whole country or a whole region of the world? Hopefully that answers the question.
Yeah, I think so. Any comments from you, Allison or Noah, around that? If not, that's okay. Okay, excellent. So thank you, Allison, Hallie, and Noah, for sharing your excellent work that you've been involved with. I just wanted to add, hang on, there's another question, great. Are there ways to combine expert-guided diagnosis codes like AlgorithmL and unsupervised learning to improve diagnosis? Nice question, David.
I guess I have less thought. I don't know about so much about the supervised learning, but I do think there is kind of a movement to use both administrative data, and clinical data. We have a sepsis registry in Michigan, and we sort of screen hospitalizations for inclusion into that to be abstracted. But we don't have the capability to screen every single hospitalization in the entire state. So you sort of take some pragmatic approaches of like, we're going to screen people with a code for sepsis or a code for sort of common different types of infection that cause sepsis. Then we look into the chart and sort of confirm that indeed, like clinically, there is evidence of treatment for infection and that there is acute organ dysfunction. And we sort of find things, that there's misclassification both ways. So there's things that are coded as sepsis, but we actually go into the chart and we're like, well, there's a temperature and an elevated heart rate, but there's no acute organ dysfunction. And so this is not actually meeting the current sort of clinical sepsis 3 criteria. And so we end up excluding them. And then by contrast, there's patients who have pneumonia and then they have respiratory failure and they're on a mechanical ventilation. And so that certainly would meet this criteria of sort of related acute organ dysfunction stemming from the infection. And so we pull those in. So I think sometimes these hybrid approaches can get farther, but we're certainly not yet to the using AI. So maybe not has more thoughts about that.
Yeah, maybe just in addition to that, I completely agree with a comment from Hallie. I do think there are opportunities to consider more advanced machine learning models. For example, one of the model is called topic modeling, which is also unsupervised. And there are existing work trying to use code-based definitions like, for example, AlgorithmL, as considering as different categories to guide the development of unsupervised learning in order to separate into different subgroups. But those subgroups are actually guided either by experts' opinion or based on particular definition of sepsis. So there are possibilities. I do think it would be interesting to see the results. But however, it's always the case that we have to balance accuracy and bias, and I don't think there is actually an optimal solution, at least right now. Yeah.
Great, thank you so much, you guys. I was curious though, how can appropriate coding support better patient experiences in the long term For example, better estimates of incidence and like the appropriate level of urgency that you were talking about, Haley.
Yeah, yeah. At least for us, like the coding happens at the sort of back end of the hospitalization by like a professional coder who sort of, translates the clinical records into this like, bill essentially for the hospital services. And, so you get these documentation queries like, could you please clarify what you were meaning here or whatever? We're sort of struggling to sort of translate this into actual diagnostic codes. And so sometimes people kind of like recoil at this. They feel like, oh, it's like busy work or something like this. But I really feel that the more precisely we are sort of defining the problem that our patient has and the more clear we can like sort of write that down, probably the better we all take care of patients, right? Like when I am attending in the ICU and I have my, trainees present to me, I always am like pushing them to be more specific, right? Like, is this a community onset pneumonia? And like, what is the specific bug, right? Like we want to evolve that kind of assessment over time as we learn more about the patient. And we also want to make it shorter. We don't want it longer and longer and longer and longer. You want to continually kind of do that. And I think we really push that in rounds with like the sort of standardized presentations, but we don't do that in the medical record where we just kind of copy and paste and it gets longer and longer. And then it's like struggle to pick up service and like sort of read through the notes. So I think that, I've tried to sort of increasingly like really push for not only on rounds being precise with our language and sort of parsimonious, but also in the medical record and like how much easier it is to sort of convey what's happening. And the better we can convey what's happening, the more the patients, I think, and everyone else can understand what's happening, including the documentation and coder people at the end. So I'll get off my soapbox now.
Excellent. Thanks very much, Haley. I really like that you brought it back to rounds. I think a lot of sepsis improvement, from what I understand and my experience in direct care, is that it's an interdisciplinary responsibility to identify and treat. And interdisciplinary rounds, of course, is a perfect opportunity to have that discussion, and would be, and always has been, really interesting to hear the medical students like interpretation and reporting and like why they think that patient is presenting as septic and why they're not. So I think that's a really valuable place to consider sepsis for sure. And we have another question about if there's any work being done to improve the SOFA scoring criteria to improve near acute classification of sepsis. Are you aware of any work around that?
Yeah, so I believe, so there is a SOFA 2 that's coming out, I think, in like 2 days or something. So it's a timely question because I think it's coming out with the European Society of Intensive Care Medicine. And but I mean, I don't know about that. That's going to help with kind of more. What was the question I'm reading here? Near acute classification. The goal is really just because, some of the stuff in there is a little bit outdated and there's like PF ratios and sometimes we use SF ratios and stuff. So it's really trying to just sort of bring it into modern day and also to provide alternative criteria so that it's like globally applicable, even in places where sort of certain things, may not be readily accessible. So that's really the goal of it. So, but yeah, SOFA 2 will be published, I think, in the next, within a week. It's my understanding.
Yeah, I hadn't realized that. I wonder how many people are writing that down right now because they're unaware that that was happening. And that's great. We'll definitely keep our eyes peeled for that for sure. I think we're near time. If there isn't any other questions, we can break for lunch. But I just wanted to say thank you to Allison, Haley, and Na for sharing this excellent work that you've been involved with. In BC, there are also groups that are starting to use AlgorithmL to identify volumes of pediatric and adult patients diagnosed with sepsis. We're using the AlgorithmL to identify 30-day and 1-year readmissions to ED and critical care for those patients that have been discharged with a sepsis diagnosis, discharged from critical care. And this will help us understand the burden of sepsis more thoroughly and collectively, I think, across the lifespan, and definitely builds on the neonatal work that's been done here in BC. That was kind of the impetus for us to be like, well, maybe we should use this for adults and pediatric patients as well. So your work is definitely going to good use. So thank you for all of the effort and pulling together all those experts to get that done.